All right. Thank you, Megan. It's great to be back. It's an honor to be here, Brian. Megan, thank you for inviting me. I do think it's always great to see the bells, and I actually think you should hire Bob Glover every year just to come in to do a cameo on that and then leave. That's like, but as I said, it's an honor to be here. I started state government, I think about 17 years ago. I think I've been out of state government for like 11 years now. As commissioner, and many of you know Val Melke, who I haven't seen here today. But this conference was always for me, it was just the annual place to be. It was like my support group, it was networking, it was all the things I really needed to just to get out of my state, get out of the crisis of the day, and come here and and get with folks. And I remember back in the time, my staff used to be back, they would dread me coming here because when I got down here, I was firing emails back up to the state folks like about we should be doing this, we should be doing that, and so it really is an honor to be here. When Brian had emailed me a while ago about doing a paper on housing and employment and case management services as it relates to crisis, in my mind, it made a heck of a lot of sense. I've sort of been a disciple of supportive housing for many, many years. Working in community mental health services for many years before I came into state service, one of the biggest things I did was develop and start supportive housing for people who were coming directly out of state hospitals, for people who are chronically homeless on the streets. And so it made a lot of sense for me to talk about these types of services as they relate broadly to recovery supports for people with serious mental illness, but particularly when we talk today about crisis services. But I was a little worried about sort of doing the talk because there's been so much energy and momentum around 988 and mobile and crisis across the country that I was a little worried that it was going to go flat, particularly when I got an email from Brian and Megan saying, we'd like you to come talk at the conference after lunch, after everybody's digesting their food, on housing, case management, and employment. But I think we put together, a paper that has a lot of good information. I would encourage you to read it, and we'll sort of pick it up from here. So how many of you feel like this in your day jobs? Right? I can relate, whether it's a state hospital issue, whether it's a legislative issue, a call from an angry constituent, you name it. I know the things that you deal with on a daily basis. And you've got tremendous responsibilities on your plates. And, first of all, just sort of having been in that seat, thank you for your service, because these are really, really, really hard jobs. Not just you as commissioners, but your staff, the things that you sort of take on a daily basis. And it can be overwhelming for folks. I certainly know that. And rightfully so. In the past several years, there's been this focus on crisis services. Our national crisis system has big gaps in it and holes in it, and for many people it just doesn't work, and all the things that we talk about with law enforcement and all of those things, for sure. So it is the right thing to spend a lot of time and attention on this, but I am going to press you on keeping focus on upstream services, and more specifically not taking your eye off the ball when it comes to the role that programs and services like supportive housing, supported employment, and case management can have in your crisis management strategies. And they can be critical to the success of your crisis system, and most importantly, the people in your system most likely to experience crisis. In the paper, we talk about crisis across 3 stages of intervention, and I sort of label them up here: prevention, mitigation, and recovery. These really come from crisis and incident command management that first responders use. So you think when you're planning about fires or disasters or hurricane, things like that, this is sort of the jargon that they use when they're doing those things. They actually add more than 3. There's 2 more: preparedness and response in there. For the purpose of the paper, we sort of condense them down into those three things. But when you think about crisis services across our systems, these are somewhat analogous to the behavioral health system when you think about prevention and responding and recovery from crisis services and things like that. They certainly resonate for me. I'm sort of a structured person, even though I don't really talk that way when I speak, but I like structure. In a previous life, before I was mental health commissioner, I was working in community mental health services. I also, and many of you heard this before, I also worked in forest fire. Basically, that was my mental health time. I would go out and fight forest fires. And so that was this sort of the the language and lingo and approach that they used when they were managing crisis, and you could think about how these might apply in behavioral health services. And one joke that I would tell folks is, even though I had the opportunity to fight a lot of forest fires, I would joke with people that in my commissioner day job, I fought way more forest fires than I did actual fire out in the street, right? You can all relate to that. But in any case, what I want you to do as we sort of go forward is really keep prevention and mitigation and recovery strategies and focus areas on your mind as we discuss how and where these services are applicable through a crisis lens. So, and Brian asked us in the paper to talk about best practices, and really we're focusing on supported housing, supported employment, and case management here. And I put 3 definitions up here. And you'll note that I have some asterisks up there. And I put those up there because I tried to think about the types of definitions that I wanted to generally get out here to the audience. And I want to be really clear. And the reason I'm doing this is because, and we're going to talk more about it as we get deeper into the session, these best practices are implemented pretty widely, invariably in your systems, right? So, you know, when I generally talk about supportive housing here, we're talking about the combination of lease-based affordable housing combined with flexible support services, case management, a range of linkage and referral services and coordination, supported employment, essentially integrated employment opportunities. But for instance, what you don't necessarily see here, and I'm sure Bob Drake and Virginia Selleck will talk about this next session, you know, this is not necessarily the Fidelity-based definition of interpersonal IPS supported employment programs, okay? But nevertheless, you know, we're going to talk about it from this framework, and we're going to talk about how those differences in these services in your systems may impact their role in prevention, mitigation, and recovery strategies. So in our paper, we highlight several points related to these services, and I just want to summarize some of them here for you. And we tend to think of these services, supportive housing, supported employment, and case management, as services that are recovery-oriented in our systems, right? But we don't always make the connection between these services in crisis or see them through that crisis lens. But nevertheless, I'm going to go through some of these points. These services, essentially, that use evidence-based and best practices provide critical opportunities to recognize the early warning signs of a behavioral health crisis and take steps to prevent it. High-fidelity supportive housing and supported employment programs serving individuals with mental illness and co-occurring disorders, including those who experience homelessness, integrate crisis prevention and intervention into their service models. When implemented effectively, these services can help reduce the severity of crises that do occur and can facilitate post-crisis recovery. And these are somewhat general statements, and you know, if you look at sort of the bibliography that we have in the paper, it's a pretty exhaustive list of citations that really start to cite the premises that I'm talking about today. Case management services that incorporate evidence-based and best practice interventions can function as a critical hub for engaging individuals, facilitating self-direction, choice, and linkages to these and other services and supports that help reduce crisis risk and assist in recovery. And you, as the behavioral health authorities, can strengthen the role of these services in crisis prevention, mitigation, and recovery through policy, funding, and practice support, and by ensuring effective coordination between upstream services that address social determinants of health and crisis services. So here's a list of key program features and strategies that we know support crisis prevention, mitigation, and recovery. And one thing you're going to sort of hear me at the end of the today, you're probably going to be sick of hearing crisis prevention, mitigation, and recovery, and supportive housing, employment, and case management. And my hope is that by the more I say it, the more imprinting that goes on in your minds, and you sort of take this away from some of the conversation today. But nevertheless, these are sort of the basic components that I really think should be required components in many of these services in your systems. And I want to repeat that. They should be required components in these programs and services in your systems. We're really trying to think about it through a crisis lens. And you probably look at this list and you can say all of these services make sense, they're logical. But again, we don't always fine-tune our thinking about if and how these services exist or are implemented in programs like supportive housing, supported employment, and case management down to this level, right? That's an important thing, down to this level, of really thinking about these things down at that level. Sure, we could say we've got supportive housing in our system, or case management in our system, but are we thinking down in our level in those policy, regulations, and funding things that I talked about, that these types of services are incorporated in these types of programs? So I'm going to rattle off some examples for you to think about as you're going forward. High fidelity supportive housing programs that make services available on a 24/7 basis and integrate behavioral health services are effective in reducing crisis risk. By maintaining low caseload sizes and routine face-to-face contact with tenants where they live, supportive housing providers are able to recognize the early warning signs of potential crisis and to adjust the frequency and intensity of the services as needed to avert a crisis. And too often, I see this fall apart in systems, giving supportive housing, for example, a bad rap, when really it may be related to how that program was implemented in the community. Case management for, and some supportive housing programs, like in Louisiana, for instance, they require providers to develop a specific crisis prevention intervention plan for tenants as a means of effectively planning for and intervening in the event of a crisis. Funding and staffing limitations may challenge the ability of ACT teams to prevent a crisis, particularly where 24/7 service availability is lacking. Modifications may also be needed for ACT teams to effectively respond to substance use related crisis, homeless individuals in need of outreach and engagement, and for those also needed housing supports. And when we talk about best practices, we generally talk about case management in the paper. We also talk about ACT as I recognize it's a treatment modality, but we also talk about it as a case management modality for purposes of this paper. When it comes to supported employment, when implemented to Fidelity with the individual placement and support model of supported employment, services emphasize the integration of employment services within clinical treatment teams and the provision of ongoing follow-along supports to help an individual maintain employment. Supported employment service providers should ensure that employment specialists are trained to identify crisis risk factors, to assertively engage individuals and offer adjustments to employment supports as needed, and to have structures and protocols in place that ensure regular and effective communication between supported employment staff and clinical treatment providers. It was funny this morning, Bob Drake and I were talking a little bit, I think Bob might have stepped out of the room, about sort of a lot of the focus of crisis services and things like that at the conference this week. But when you look at the evidence, as it relates to supported employment programs, there's a lot of good positive outcomes in helping to prevent and resolve crisis. Yakima Neighborhood Health Services, which is a supported employment provider based in Washington State, also delivers supportive housing and healthcare services, allows supported employment and behavioral health clinical staff to share an electronic database in order to more effectively coordinate services. So you're getting at that coordination piece of it. Georgia, the GCAL line allows center staff to identify ongoing behavioral health service providers and request provider follow-up at the time of initial crisis. Here in DC, staff across the continuum have access to a centralized database which allows staff to identify and coordinate with existing providers, including supportive housing providers, at the time of crisis. Connections Health Solutions in Arizona, which we've heard about, incorporates transitional case management services into the crisis stabilization unit manages in order to connect individuals with services and supports that prevent re-emerging crisis. A couple more. Washington State's Peer Pathfinder program assists individuals who have experienced a substance use related crisis with peer engagement and connection with behavioral health and other services, including supportive housing and supported employment, following utilization of hospital emergency rooms. Back on Georgia, the High Utilization Management Program, and I'm sure Wendy will hit me up later with an email if I mess anything up, and Judy too. So hopefully I'm not, I'm doing you a little bit of justice there. But offers short-term intensive care coordination, service linkage and referrals for individuals who have a history of high crisis service utilization and are disconnected from community-based services. Following acute hospitalization, the Pathway program in New York connects individuals with significant behavioral health challenges who are not otherwise linked with behavioral health services to intensive support, short-term and mobile case management in order to help with the transition back to the community and ensure ongoing connection to supports to address social determinants of health, including rapid connection with housing. And finally, in North Carolina, providers go through a provider readiness assessment to be eligible to become a community support team provider or a supportive housing provider that assesses if they coordinate care with existing new providers related to, among other things, emergency and urgent care. And they also have individual crisis prevention plans that address potential issues that could jeopardize housing and lead to eviction. So important in all these examples that I mentioned are two things that I sort of want you to take away from. One is they get into the weeds of prevention, mitigation, and recovery strategies, right? So not only are they having these services in their systems, but you can see they've actually got into the weeds of creating interventions and making sure that we're talking about crisis planning, 24/7 availability, service coordination, referrals, handoffs, all of those things that we know are so important in the crisis continuum there. And the second thing is they all have had the ability to have capacity built into their upstream services, upstream of the crisis system. Even though it relates to crisis services, they're built in upstream. And I think those are two important points for you to consider. So supportive housing, I'll talk a little about supported education, supported employment, case management, all generally, and I say generally, have evidence to support a reduction in psychiatric hospitalization days and emergency room usage, okay? So let's assume you in your states as commissioners and state staff have supportive housing, supported employment, and case management in your systems. In many systems, these services are targeted toward people with the most complex mental health conditions, particularly when viewed through an Olmstead lens. And so many of you know I do a lot of Olmstead-related work, right? And so if you're a state who is doing Olmstead planning, or you've got a settlement agreement, or DOJ is investigating you, right? The actions, the remedies that are all sort of embedded in these Olmstead actions for individuals who are most likely to be in segregated settings, the most complex conditions, are supportive housing, supported employment, case management, ACT, things like that, right? Right? But here's the reality check. We're all over the map in what these programs look like in our systems, okay? How accessible they are, their flexibility, their intensity, scalability, geographic penetration, rural considerations, workforce issues, fidelity, and certainly on specific aspects of crisis prevention, mitigation, and recovery. So I talked a little bit before and laid out some definitions of best practices in these areas. But again, it's hard to sort of pinpoint that across 50 states. And within your 50 states, some of your county systems, some of your state systems, some of it's very, very local. We're all over the map. We're all over the map in terms of these issues, caseload ratios, all of those things. No, I'm not quite there yet. I'm going back. Sorry. Some of these services are not even on the radar in systems for some providers. You know, a little bit of a personal example. I have a daughter who is 19. She has serious bipolar disorder. She's living on her own in an apartment and going to college in a pretty big city in the country. And she had a hospitalization this past winter, which was actually more medically involved. She actually, when she went into the hospital, she wasn't admitted to the psychiatric unit. She was admitted to medical. She was put on a 72-hour hold. I flew down there to help out. And she stabilized medically after being in the ICU for a couple of days. It was related to lithium and lithium toxicity. And the discharging psychiatrist came down to talk about discharge and what were next steps and to evaluate her to see if they wanted to keep her in the inpatient unit. And she didn't need to be on the inpatient unit. And I was there, and the psychiatrist agreed. But the recommendation for her was to go to the partial hospital program for 5 days a week for, you know, a couple of months or whatever. And my daughter, who wasn't really there for a primary psychiatric reason, said, well, I've got class in college on Wednesday I've got to get to, you know, and the doctor was sort of pressing her about the need to go to partial hospital. She could benefit from it. And all that to say, and long story short, we worked it out, and my daughter was her own best advocate in that case, after me threatening to go to the state commissioner and all that stuff. They're like, who are you? Because I really don't have any clout anymore. So she ultimately didn't go to the partial hospital program and went back to her college, and she's doing fine. But it's important just to note that you know, deep in our systems, you know, people are well-meaning but don't necessarily sort of have the privy or the benefit of sort of understanding all of these things. So If people with serious mental illness and highly complex conditions are most likely to experience a crisis, how do we make sure they have access to these services? How do we ensure that these services can meet their needs, including preventing, mitigating, and recovering from crisis? How do we build that into those services? And so I think for all of you, there's some questions to ask yourself in your roles as you go back to your states. What do I do here? All right. Maybe it's not good enough to have just supportive housing, support employment, and case management in our system. But it's that. A, do you have these in your system to begin with? Are they to scale? Just because you have an ACT team or one PSH team in a geographic area does not mean that you have statewide access or coverage for that service, or availability to meet the number of people who need that service. Do they incorporate best practices? Do they consider fidelity measures in these services? Are they required to have crisis prevention, mitigation, and recovery strategies and services built into their programs, right? That's where you all come in. Do they have enough of these three types of services to meet the demand? Does the service have the capacity to meet the actual need? So reflecting back on that jack of all trades slide, here's where I'm sort of piling on to encourage you to think about these things, not yet as another thing to add to your to-do list, but that thinking about these things is part of your crisis system reforms as well as your upstream strategies. Yes to 988. Yes to mobile. Yes to CSUs. But the success of our crisis system also relies on the success of our core upstream services for the people most at risk of crisis. So in the paper, we lay out some recommendations, and I'm going to sort of run through those for you. First, I think it's really important to commit to making supportive housing, case management, support employment services more available and accessible within systems to address social determinants of health from that perspective, reduce crisis risk, and support individuals in recovery, right? I think it helps you achieve multiple aims in your systems. Policies, regulations, service definitions, and performance monitoring should reinforce key features of these services that make them effective in crisis prevention, mitigation, and recovery, and ensure their alignment and coordination with crisis response system. So sometimes when you think about, well, a lot of what we do now, it's handed out by managed care or the providers are responsible for doing that. But when it comes from the seats that you sit in and your levels and layers of influence, and you think about how through policies and regulations and service definitions and things like that, you can actually ensure that these types of not only high-level services, supportive housing, for instance, but the types of crisis prevention, mitigation, and recovery strategies are infiltrated down at the local level for folks. Coordinate with state Medicaid agencies to ensure sufficient funding and coverage to support effective implementation of these services, along with adequate provider rates, ding, ding, right? How much we hear that? And factoring the role in crisis and also integrating peer supports. And I think everybody's generally trying to have really good relationships with their state Medicaid agencies, and you see really good pockets of it in states, and sometimes that ebbs and flows depending on administrations and budgets and all of those things. But we really need to have the best possible relationship with Medicaid. Sometimes it's just convincing them that some of these things are really important too. And supportive housing, case management, and employment service providers should be equipped with guidance, tools, and protocols, and offer training and technical assistance to ensure they can effectively assess, plan for, and intervene to prevent or resolve crises as needed. They should also be trained on protocols for accessing local crisis systems and services, right? So great if we put things in at a high level on policies and regulations, but pushing it down into our workforce, right? Given all the workforce challenges we have, knowing that our frontline workforce who tends to be working in these types of programs is young, inexperienced, green, and turns over pretty rapidly. And some of the deeper end, for lack of a better word, of our system, it can be really draining and taxing and stressful and at times traumatic. And so we have to make sure that we're pushing these things down for folks. If nothing else, take away from this discussion today that supportive housing, supported education, supported employment. I'll keep going about it, supported education, because it's so on my mind for my daughter. And it's a new generation, right, Bob? We got to sort of think about that. That those services, and I would suggest all upstream services, right? When you think about the range of upstream services and best practices that exist in our systems, must incorporate prevention, mitigation, and recovery strategies to help you achieve the best outcomes possible in your systems. So many people in our systems are in recovery, right? And we've heard all these tremendous stories over the last couple of days about recovery and recovery journeys. And in the mental health system in the past 10, 20 years, we've created lanes and opportunities to create that space. And it's been a lot of hard work. But mental illness can be terrible for people, right? And we need to work towards making upstream programs as comprehensive and supportive as possible and accessible, right? We heard access a lot, right? Access. People most likely to experience crisis in your systems need them, and the success of your crisis systems depends on them. Thank you. So yeah, if anybody has any questions, comments, feel free. I think we've got some time.
Hi, thanks. That was a great presentation because whenever, I'm Margie Balfour with Connections Health Solutions in Arizona. But whenever people ask me like, well, what more do you need in your crisis system? What would you change? I'm always like housing, and then number 2 would be housing, and then number 3 would be housing. And so I really liked what you talked about, and I just wanted to kind of make a point too that these are upstream, but it's a cycle, or it often is a cycle. So what is upstream is also for us on the back, downstream. And there's this idea that I think needs to be like considered of moving at the speed of crisis. Like there used to be this commercial back in the 90s for like FedEx or UPS or something, and like we moved the speed of business. Well, like there's the speed of outpatient and then there's the speed of crisis. And so a lot of times some of these services will be available, but it's like, well, it's Thursday. We'll have a meeting about it on Monday. And I'm like, no. Mm-hmm. Or like, well, this form has to be done, then it has to be authorized, and then blah, blah, blah. And what happens is those people who are in need of that kind of these resources for discharge planning, they default to the hospital, and it is completely preventable. Mm-hmm. So I would also recommend keeping in mind the access to these services need to be able to mobilize quickly, because when you lose your housing, I mean, that's like losing the bottom of your Maslow's triangle that you live on. And so that is a crisis in and of itself. Yep.
No, thank you. It's spot on, Margie. At TAC, where we work, we do a lot of work in behavioral health and Medicaid. We also do a lot of work in homelessness and affordable housing. And on the housing side of the world, there's a lot of focus on folks who are chronically homeless. Obviously, many of those folks have mental illness and substance use disorders, and veterans. And HUD and the VA in the last 5 or 10 years now have created sort of what's called a rapid rehousing model. And essentially, it's rapidly getting people housing off the street, right? And they put a ton of resources out there for it. And one of the conversations I've tried to have with some of our staff and some folks at HUD is to try to think about those rapid rehousing strategies for people with mental illness who may be in crisis. Because, right, you go to an emergency department, and if housing is one of the, maybe it's the primary reason for your crisis, or at least one of the underlying foundations of it, and you're stabilized and you have still no place to go, and you're going back out to the encampment under the bridge on 95 or something. And so I think from a mental health community perspective, it's something where I would love to see NASMHPDs and other mental health advocacy organizations start to push more of those housing conversations with our federal partners at HUD, because we need to create more of those rapid access to housing, not just the services, Margie, but the access to housing. So thank you.
Yeah, thank you. Thank you for this. I'm Neil Bowen. I'm the commissioner from New Mexico. And I thought long and hard about making this comment, but I recently had the pleasure of serving on the Housing Commission for the state of New Mexico. We were tasked with creating a housing plan for the next 50 years. And at first I was a little perplexed about why I was put on the commission, and quickly discovered that most of the housing industry folk considered mental health issues and behavioral health issues as one of the biggest obstacles to success in their projects. So it became clear to me why I was there. And so I really look forward to reading the paper because of the comment about building in prevention, mitigation, and recovery, which is our side of the street. But the real reason I brought this up is 2 issues that came up in that work that I did with that commission, that I'd just be interested to hear about considerations from our perspective of the behavioral health side. And the first is, we were talking about how we build sufficient housing over the next 50 years, and I, cautiously raised my hand in the first meeting and said, we're not talking about climate change. how can we make a plan for 50 years if we're not talking about climate change? And how do we build in a plan for housing that recognizes that we're not in the new normal, we're on the escalator still going up. And so part of the pushback I got from some of the behavioral health community on that was that the behavioral health folks who had supported housing didn't want to live in condensed units or in kind of urban environments where you can walk to the supported employment or something like that. And I think those are things that we really have to think long and hard about helping people understand that we need to change the way we're talking about housing in order to have sustainable housing going forward for everybody, including our folks.
A few years ago, maybe 8 or 10 years ago, I wrote a paper, and I forget what it was titled, but it was essentially making the point that the visible problems or symptoms of the mental health system, right? And by visible, I say homelessness, incarceration, and institutionalization. Are largely sort of blamed on, blames sort of cast to the mental health system for being failures. And it's not to say we don't have lots of challenges. But the premise I built up in that article was it's a failure of housing policy in this country, in being able to sort of meet the needs of not only people with mental illness, but people with disabilities. And, when you look at, we have maybe insurmountable is not the right word, but we have a true affordable housing crisis in the country, not just for people with mental illness and people with disabilities, but for everybody, right? We do a report at TAC every so often, it's up on our website, but that nowhere in the country can a person who's on SSI, right? So you think about many of the individuals who we serve in our systems, nowhere in the country, in one single housing market in the country, can they afford housing at the fair market rent, right? Nowhere. And so, you could think about, well, do we build more housing, right? Well, yeah, that's part of it. And you work with tax credits and things like that. Can we rent housing? Well, the federal government, particularly under COVID, put a tremendous amount of resources into housing for rental assistance and frankly, got a lot of people off the street. But the rental market in this country is there's 0 vacancies and the rents are off the charts, right? And so I don't know what the solutions are, right? There's housing solutions. But one of the things that we talked about, and I think Bob and Virginia will talk a little bit more, right, is the poverty that folks experience and the unemployment and underemployment, right? Now, we've got a long way to go there too, but we also have to figure out a way to get more resources in people's pockets so they can at least be somewhat competitive in the rental market. So there's not a solution there, but these are really complicated issues on the housing side. And I talked a little bit earlier about things fall apart often in systems. It's making sure if we're going to serve people who have a lot of needs in supportive housing that we have the right supports. Too often we see supportive housing being a model known as, well, they've got to be stable. They've sort of achieved and graduated from supervised programs. And if they can't do it, if they need to be seen every day, then maybe they shouldn't be in the supportive housing program. Doesn't work. The model is we're serving people in these settings, and we have to make sure that if they're in supportive housing, and maybe if they're starting to experience a crisis and not doing so well, that service team can ramp up and see them every day, right? And you see this all the time. I mean, there's a project that I'm working on in the city that reviews 911 calls, and so I've literally been reviewing thousands of 911 calls from the call record that comes in through body cam footage of the outreach that happens, and some of these folks are calling and they're part of supportive housing programs. And they haven't seen their caseworker in a month, And so what do? They call 911, right? So we have to make sure that, we're stepping up on the services side too. And again, I fully appreciate the workforce issues and all that stuff. I don't mean to bash. I know it's a really hard issue. Brian.
Yeah. So a few years ago, I was at a meeting, and at the meeting there was a young woman who had a psychotic episode when she was, I think, 16 or 17. And the reason I was talking to her is because she was from my home community. And I happened to be at the same meeting she was at. And she and her mother were presenting on what happened. And they talked about how difficult it was to get into any type of a program. It took a while, but eventually they got into a first episode psychosis program. And she was really a success. She had gone through the program and had done well, was a nurse at Johns Hopkins.
Mhm.
So I was saying to her, well, what happened? What was the key thing that happened that helped you to be successful? And of course, I'm a psychiatrist, and I thought she was going to say that she was given medication and everything changed. Bob knows this is true, right? Bob? That's what Bob believes. Give people medication, they do better. But she said no. She said, what really helped me was that I was so worried about school and the first episode psychosis program, the program I was in, they helped me keep up with my peers. Mm. And that was what made the difference. Mm-hmm. So the reason I'm bringing it up is because you want to talk about education. Mm-hmm. You keep talking about supported education. So I wanted to give you an opportunity to say a little bit more about supported education.
I don't know. I think it's an area where, like, I go back to when supportive housing was becoming a thing, right? And we had so many hurdles to get over to make the pitch that supportive housing could be effective for folks. And you could think about it even now, like with crisis services, like we've got to put so much time and energy into making the case for crisis services, or so much time and energy in making the case for supported employment, for instance, right? And I think generally we've made the case on a lot of those things. And it doesn't mean we're done by any stretch of the mean. We've got a long way to go in all those areas. But one of the things we don't talk about is sort of what's the next generation of things. And supported education, I think, is one of those types of things that we have to think about for folks. And how do we sort of think about it in our systems, create best practices, research it more, study it more, so that, people may want to go into peer support specialist careers. My daughter wants to be like a top 10 hit singer or something like that. And if that doesn't work, she may be a teacher. So I don't think she wants to go become a peer support worker. She'd be great at it, but she doesn't want to do that. And so she could benefit from really those schools helping her. And so I just think we need to think that way as a field. Great, with the supportive housing, we still got a long way to go in supportive housing. But we know it works, and I think it's generally accepted. How do we sort of push forward? There was a guy I used to work with, so this is like around 2000 before I went into the state in early 2005. And I was running a supportive housing agency, and our focus was really taking people directly out of the state hospital, long periods of time in the hospital. This individual had a bachelor's degree. Both of his parents were PhD mathematicians, really intelligent family. He developed schizophrenia in his first year of college, got really, really sick, assaulted his father, was found not guilty by reason of insanity for the assault, spent long term in the hospital. Long story short, he was getting ready for discharge and didn't want to go to the day program. He wanted to go back to school. And it was a long challenge to get lots of folks there, even the court, and we put it in place and worked with the school and really developed some good supportive plans for him. Our team worked with the school. I worked with him as I was the executive director of the organization, but I still worked with him directly. And he went on to get his master's degree in social work. And he had paranoid schizophrenia and very little insight, but he got like 110 in his psychology class because he was that smart. And we sort of helped him through it, but it was really a supported education approach combined with the supported housing approach that really got him there. And, if we had sort of said, well, he's coming out of the state hospital, NGRI, he's got to go through the traditional linear, supervised setting, he probably would have failed. And we took a chance on him, put him in supportive housing and supported education, and tremendous success rate. As far as I was there for 6 or 7 years before I had started my work in a state, he didn't have a single rehospitalization. So that's where we've got to go.
Kevin, thank you so very much.
Thank you.
Really appreciate it.